Our patient is a 55-year-old male who presents to the primary care office complaining of right-sided leg numbness. It initially was intermittent over the last 2 months, but in the last week it has become constant. He describes it as pins and needles. Nothing makes it better or worse. It is down the lateral calf to the toes. He also admits to some back pain in the lumbar region that has been progressively worsening for the last 6 months. Based on the patient's presenting symptoms, we formulated the following differential diagnoses: disc herniation, caudal equina syndrome, PAD, diabetic neuropathy, spinal stenosis, spondylolithiasis, spondylosis, and spinal tumor.
The first and most important component of our exam includes introducing ourselves and the demonstration of proper hand hygiene practices. Upon meeting the patient, the provider begins formulating the general survey. You'll be looking for things such as apparent state of health, signs of distress, personal hygiene, appropriate dress, and odor. Vital signs: the exam will begin by measuring the blood pressure. Make sure the arm is free of clothing, fistulas, lymphedema. Position the cuff 2.5 centimeters above the antecubital crease, ensuring that it fits secure. Palpate the brachial artery to ensure the arrow on the cuff is over the brachial artery. Position the arm at the level of the heart. Slightly flex the patient's arm at the elbow. Next, palpate the radial artery. Inflate the cuff until the radial pulse disappears. The reading at which the radial pulse disappears, add 30 milligrams of mercury, and that is the target number to inflate the cuff. Deflate the cuff and wait 15 to 30 seconds. Then position the bell of the stethoscope over the brachial artery to listen to the blood pressure. Inflate the cuff to that target number. Deflate the cuff slowly at a rate of 2 to 3 milligrams of mercury per second. The sound of at least 2 consecutive beats is called the Korsakoff sounds. This is the systolic pressure. Next, identify the diastolic blood pressure. To confirm the disappearance, I will listen at the pressure falls another 10 to 20 milligrams. Then deflate the cuff rapidly to 0. Repeat on the opposite arm. Next, we will measure the heart rate. Palpate the radial pulse using your index and middle finger, then timing on a watch. Count for 30 seconds if the rhythm is regular. If the rate or rhythm is irregular, measure for 60 seconds. As you're doing this, note the rate, rhythm, amplitude, and contour of the pulse. As you're doing this, observe the patient's breathing, noting the rate, rhythm, depth, and effort of their breathing, counting the number of respirations for 60 seconds. Next, we will take their temperature using an oral thermometer. Placing it underneath the tongue. After taking the temperature, next we will measure the patient's height and weight. We will be combining the skin and peripheral vascular exam. First, we will begin by inspecting the color, the skin of the lower back, legs, and feet for rashes, lumps, lesions, scars, ulcers, color changes, hair loss, ecchymosis, obvious deformities, and swelling. Next, we'll have the patient lay on their back. We're going to palpate the femoral arteries. Then you'll have the patient sit up. We'll palpate for the popliteal. Comparing bilaterally. Next, doing the posterior tibialis. The dorsalis pedis. As you're doing this, you'll be noting the rate, regularity, and amplitude.
We will now be beginning the lung and heart exam. First, we will fully expose the anterior, posterior, and lateral portions of the thorax prior to inspection. Forgetting to fully expose the patient is a major mistake that many students miss key details essential to prior diagnosis. We will begin the initial survey of the anterior, posterior, and lateral thorax. A clinical pearl that we should not forget includes ensuring that the patient is taking deep breaths and that their hands are on their hips for the anterior and lateral positions and in crossed and genie positions for posterior. After we complete our inspection, we will then auscultate using the diaphragm of the stethoscope. We first must make sure that the patient is breathing through an open mouth and that the patient's head is turned away to avoid being in range of exhalation. Ensuring that we listen through full inspiration and expiration, we will auscultate bilaterally in 6 areas anteriorly in a lateral style pattern. Then 2 areas laterally. And 5 areas posteriorly. Making sure not to forget the apices, which is a common area that can be missed. We will now be doing the heart exam. First, we will get the patient into proper positioning, which includes a supine position of the patient with the head of the bed set at 30 degrees. Failure to get the patient into proper position can alter our findings. We will now be auscultating. To begin auscultating the heart using the diaphragm of the stethoscope. Once again, make sure the patient is in proper positioning. Begin auscultation using the diaphragm of the stethoscope at the right second intercostal space. Then progressing to the left second intercostal space, the third, the fourth, the fifth, and the apex. Repeat again using the bell of the stethoscope. Don't forget to listen for 2 to 3 seconds in each area.
We will begin the neuro exam first by testing sensory using the light touch. Have the patient hold out their hand, touch the palm of their hand with the cotton wisp. Ask the patient, can you feel this? Each time you feel the cotton touch, say now. Once you have touched one side, then the other, ask the patient, do they feel the same? Have the patient close their eyes. With the cotton, touch the lateral thigh, both sides bilaterally, the medial side of the thigh bilaterally comparing, the lateral side of the calf, the medial sides of the calves, the great toe. Each time, next you evaluate proximal to distal by touching the medial calf to the big toe, each time saying when they feel the cotton wisp. Next, we will begin pain sensation. Using the sharp end of a broken cotton swab, have the patient hold out their hand, touch the palm of their hand with the sharp end, and then with the dull end, asking the patient, is this sharp or dull? Occasionally substituting the dull end for the sharp end and asking the patient to differentiate. Have the patient close their eyes, touch the lateral side of their thigh, the lateral side of the opposite thigh, the medial side of the thigh, the medial side of the calf, medial side of the other calf, the lateral side, and the opposite lateral side, the big toe, and the opposite, and then comparing proximal to distal, medial side of the calf to the great toe, medial side of the calf to the great toe. Applying the lightest pressure needed to feel the stimulus of the sharp, but not hard enough to draw blood. Next, we'll perform the vibratory sense exam using the 128 Hz tuning fork. Have the patient close their eyes. Strike the fork to engage the vibration. Place the tuning fork on the patient's IP joint of the great toe. Ask the patient if they feel the vibration and when they feel it stop. Repeat on the other side. In peripheral neuropathy, the vibratory sense is the first sense to go. Next, we will evaluate the deep tendon reflexes. First, with the patellar. This evaluates L2, 3, and 4. Strike directly on the patellar tendon with a flexed knee, looking for a response. Next, testing the Achilles, which is evaluating S1. Strike directly on the Achilles tendon. Watch for the patellar reflex. Making sure to support the patient's foot to get a true reflex. Next, doing the plantar response. This evaluates L5 through S1. On the bottom of the foot, slide the bottom of the reflex hammer laterally and then medially. A positive test, the great toe extends, which is a Babinski sign. If the test is negative, the toe plantar flexes, which is a negative test. A positive test can indicate a spinal lesion. A positive test in an adult is normal in babies.
We will now be beginning the musculoskeletal exam, beginning with the spinal column. Having the patient standing upright and exposing the SI joint to the base of the skull. The instructor will inspect the spinous processes for paravertebral muscles, iliac crest, posterior superior iliac spines for trauma, spasm, deformity, swelling, erythema, posture, and smooth coordinated neck movements. He will inspect from the side for spinal curvature. Now we will be palpating. While the patient is standing for tenderness and spasm, palpate the spinous processes, lumbar area for step-offs, sacroiliac joint, and paravertebral muscles. We will now be doing active range of motion. Flexion, we will now instruct the patient to bend forward and touch their toes. Extension, instruct the patient to bend as far back as possible and support by placing your hand on the posterior iliac spine. Now right and left rotation. Instruct the patient to rotate or twist from side to side and support by placing one hand on the hip and the other on the opposite shoulder. For right and left tilt, which is also called lateral bending, instruct the patient to bend to the side from the waist and support the patient's pelvis by placing your hands on the patient's hips. iliacs, we will be inspecting for obvious deformity and color change. We will be palpating the iliac crest and anterior superior iliac spine. Okay, active range of motion. While supine, for flexion, instruct the patient to move knees to chest. For extension, instruct the patient to move legs back out. For abduction, instruct the patient to move leg away from midline. For adduction, instruct the patient to move legs across midline. While sitting upright, for internal rotation, instruct the patient to bend knee and move foot laterally. For internal rotation, instruct the patient to bend knee and move foot to groin. For strength against resistance while standing, we will be assessing flexion, extension, abduction, and adduction. Strength against resistance.
Flexing this front hand. And kick back. Next time, come across. And we'll do the same thing on the side. Straight out. Straight back. Bring your leg back. Okay, out. And across.
We will now be looking at the knees and inspecting for alignment and contour, atrophy of the quadricep muscle, loss of normal hollows around the patella, swelling, effusion, deformity, nodules, and color. We will now be palpating while sitting for the medial and lateral and tibial tuberosity, and also for the patellofemoral joint and patella. For active range of motion, we will be assessing extension. Instruct the patient to straighten the legs out. For flexion, instruct the patient to bend the knees in. We will now be doing strength against resistance for flexion and extension. Now for the ankles and feet, we will be inspecting for swelling, deformity, nodule, and color. We will be palpating the anterior aspect of the ankle joint, medial and lateral malleolus, metatarsophalangeal joints, calcaneus, and digits. We will begin active range of motion with dorsiflexion. Instruct the patient to point the toes towards the ceiling. For plantar flexion, instruct the patient to point the toes down. For inversion, instruct the patient to move the bottoms of their feet toward each other. For eversion, instruct the patient to move the bottom of their feet away from each other. We will now be assessing strength against resistance for dorsiflexion and plantar flexion. We will now be doing special tests beginning with the Faber test, which evaluates for arthritis and sacroiliitis. While the patient is supine, place the foot of the affected side on the opposite knee. Press on the flexed knee and opposite anterior iliac crest. A positive sign would elicit pain in the hip or sacroiliac joint. We will now be doing it on the other side. Another special test we will be doing is a straight leg test, which will be evaluating for lumbosacral radiculopathy. The patient is supine position. Raise his relaxed and straightened leg, flexing the leg at the hip, then dorsiflex the foot. A positive test would be pain radiating into the leg. Dorsiflex may further increase the leg pain. For our final special test, we will be doing the Romberg test to assess for overall balance and position sense. The patient will stand with feet together and arms by his side, with eyes open and then closed for 20 seconds. A positive test sways with eyes closed. And that will be the end of our physical exam.